Okay, so continuing with chapter 3, we're on page 60. We're looking at the chart. We're looking at common cardiovascular drug interactions. So let's do something that we already talked about. So we did a case study on warfarin. So we're at the bottom of the chart. So let's just reread what we already talked about. So risk and actions. So when we're looking at things that might inhibit warfarin, we're thinking about like cytochrome 2C9 inhibitors. So for example, the azole antifungals, we're thinking about amiodarone for sure. We're also thinking about metronidazole, and we're also thinking about Bactrim, the sulfamethoxazole trimethoprim. So with the cytochrome 2C9 inhibitors, what happens when that's taken with warfarin? So we will actually see the increase in warfarin levels, and we'll see the increase in the INR, and we'll have an increased bleeding risk when we have warfarin taken with any of the drugs that would inhibit its metabolism. And then we want to review medications that would induce warfarin. So the two common medications that we would see would be rifampin for sure, that would induce warfarin's metabolism, and also St. John's wort. So again, the inducers would cause lower levels or subtherapeutic levels of warfarin, which would cause a lower INR and also increase risk of clotting in that patient. So we have to really make sure to, in our notes, that we have been monitoring the INR, and we want to make sure that the INR is in the therapeutic range. For some patients, it may be therapeutic ranges between 2 and 3, but for some patients, their therapeutic range may be different, so we have to check the chart. Some patients, it might be like 2.5 to 3.5. So we just have to definitely, again, make sure we know what their therapeutic range is. And some drugs like amiodarone require prophylactic warfarin dosing adjustments when they start the medication. So we're going to go and look at amiodarone next. So again, if a patient is taking amiodarone and then we add warfarin, we want to make sure that we handle that properly. So they can be used together, like for AFib treatment, to control rhythm, and we want the warfarin to reduce clot risk. They may also use, instead of amiodarone, they could use dronedarone, which has similar drug interaction issues. So amiodarone or dronedarone may be used. So again, let's look at the risks. So amiodarone would inhibit multiple enzymes, especially like we just talked about, cytochrome 2C9, which again, it's inhibition. And so with inhibition, we're looking at higher levels of warfarin. So the patient, the notes here say, if using amiodarone and then adding warfarin, you would want to make sure that the patient is started on a lower dose of like 5 milligrams or less. If they're using warfarin first and then you're adding amiodarone, you would want to have like a reduced warfarin dose of like 30 to 50% depending on the INR value. And again, you would want to monitor their INR and adjust as needed. But again, that interaction is going to be an inhibitory interaction. And so you're going to have a bleed risk there. Due to reduced warfarin metabolism, high INR, just to remind everybody. Then there's another interaction that we need to look at that is common with cardiovascular patients. So with amiodarone, a patient may have to be put on digoxin. So these can be given together, again, for atrial fibrillation treatment, for rhythm control, for the amiodarone. Digoxin would be for rate control to reduce the heart rate. It could also be for symptom improvement in a patient with heart failure. So the amiodarone inhibits P-glycoprotein, and then the digoxin is a P-glycoprotein substrate. And so we're going to have reduced digoxin excretion, and this could cause digoxin toxicity. So we want to look out for any adverse drug reactions and signs of dig toxicity. Amiodarone and digoxin will both reduce heart rate. They will both cause risk of bradycardia, and so we really have to monitor accordingly. If we're using amiodarone first and then we're adding digoxin, you would want to start with an oral dose of digoxin that is a low dose, like a 0.125 milligrams daily. If you're using digoxin first and then you're adding amiodarone, you would want to reduce the oral digoxin dose by 50%. Like, for example, change the 0.25 milligram daily to 0.125 milligram daily, or change 0.125 milligram daily to 0.125 milligram every other day. For a patient who is taking both amiodarone and digoxin, you'd want to counsel them to be aware of what symptoms would look like for digoxin toxicity. So nausea, vomiting, vision changes, and if any of that should arise, they have to contact their doctor. Monitoring parameters, heart rate, normal normal heart rate would be like 60 to 100 beats per minute. Could be lower based on their history and their physical state. Check for other drugs that would reduce their heart rate. So beta blockers could reduce heart rate, clonidine, diltiazem, verapamil. If digoxin is being used for rate control, inform the prescriber to consider beta blocker or like carvedilol or a non-dihydropyridine calcium channel blocker instead. And if the patient is taking digoxin and then you add on like a loop diuretic like furosemide, these can be given together for heart failure treatment. The digoxin would be for symptom improvement, and the loop diuretic would be to alleviate symptoms for fluid overload. But remember that the loop diuretics cause a reduction in the potassium, magnesium, calcium, and sodium levels when you take labs, and the low values of the potassium, magnesium, and calcium can actually worsen your arrhythmia. Digoxin toxicity risk is actually increased with reduced potassium and magnesium levels and increased calcium levels. Caution: heart failure and renal impairment often occur together. Digoxin is cleared by P-glycoprotein and excreted by kidneys. Renal impairment, which can be exacerbated by loop diuretics, we will see increased dig levels and risk of toxicity. So if taking dig and loop diuretic, we want to monitor electrolytes, and then we need to correct them if they become abnormal. We want to check for any renal impairment. We may have to reduce the digoxin dose or frequency, or even discontinue. We again have to look for drugs that would decrease heart rate, like calcium channel blockers or beta blockers, which are used often for rate control. So diltiazem, verapamil, carvedilol, clonidine, and so these can have additive effects when the drugs are used to control heart rate and reduce heart rate are used together with like amiodarone, digoxin. So we need to monitor heart rate. The normal heart rate should be between 60 to 100 beats per minute. For some patients, they may have a normal lower heart rate just based on their history and physical state. And the last section on page 60 gets into looking at cholesterol medication. A lot of patients in this group will have high cholesterol, which is like a lot of them will be on some statin. So we have to really be careful with some of the statins that are strong cytochrome 3A4 inhibitors. So the ones that are the strong 3A4 inhibitor substrates would be like simvastatin, Zocor, atorvastatin, Lipitor, lovastatin, and if these are given with inhibitors, like 3A4 inhibitors, including like erythromycin, clarithromycin, ketoconazole, fluconazole, cyclosporin, grapefruit juice, stuff like that, there can be a greater risk of myopathy so muscle pains and rhabdomyolysis. So simvastatin and lovastatin are actually, here's the notes for the provider. Simvastatin and lovastatin are actually contraindicated with strong cytochrome 3A4 inhibitors. Recommend a statin that is not metabolized by cytochrome P450 enzymes. So definitely rosuvastatin, which is Crestor, or pravastatin or pitavastatin. And we'll go ahead and take a pause there. That's the first chart on page 60.